So, dear Chairman, dear audience, let me greet all of you and allow me to present the progress regarding my PhD thesis entitled, actually, Effect of Anti-Inflammatory Medication on Venous Thromboembolic Risk in IBD Patients. I am Hajnal Székely, working as a medical doctor at the Department of Surgery, Transplantation and Gastroenterology, with the vision to improve the IBD patients' quality of care by extending the knowledge regarding some important clinical factors of this complex systemic disease. Within our work, we have two ongoing goals. The first one regarding the most commonly used anti-inflammatory medication, and the second one regarding newer biological and small molecules. The first one methodologically being a systematic review and meta-analysis. The second one planned to be a prospective study. So it is common knowledge that patients with IBD have a around 2- to 3-fold increased risk of venous thromboembolic events compared to the general population. The average prevalence of this complication is reported to be between 1% and 8%, although it's remarkably higher in autopsy studies. If this complication appears, it is considered to be a relevant cause of morbidity. It results in longer hospitalization, has a tendency to recur, but of utmost importance is the fact that it may be potentially fatal. The mortality rate of these events it is considered to be between 8% and 25%. In IBD, the venous thromboembolic events are considered to be multifactorial. Besides well-known risk factors, here we have to encounter some disease and treatment-specific characteristics like extensive disease in ulcerative colitis, colonic localization and fistulizing behavior in Crohn's disease, as well as active disease flare and consequent hospitalization in both disease phenotypes. Regarding therapy-related risk factors, the need for surgery and the corticosteroid therapy have a proven effect. Regarding other treatment options available in the treatment of IBD and their relation to the venous thromboembolic events, the data are relatively scarce. So regarding tumor necrosis factor alpha inhibitors, it is known that they are effective in inducing and maintaining remission of IBD and also to decrease the rate of certain complications like the hospitalization and the need for surgery. And if you take into account the TNF alpha, it's not just a pivotal molecule and a important driver of the inflammation in IBD, but also may activate the coagulation cascade. We may presume that by inhibiting this cytokine, we may interfere somehow with the coagulation process. So our aim was to compare, based on these presumptions, the effect of anti-TNF drugs compared to conventional IBD therapy on the venous thromboembolic risk. So the clinical question that we formulated, we used the PICO framework, and our hypothesis was that anti-TNF drugs are associated with a decreased odds of venous thromboembolic events compared to the conventional IBD therapy. So for data collection, we pursued a comprehensive systematic search, and you see here that out of more than 10,000 hits, at the end of the selection process, there were 18 articles considered to be eligible for our project. We were able to include just retrospective cohort and case-controlled studies, as randomized controlled trials are not available in this topic. So we selected articles reporting the number of venous thromboembolic events in the distinct treatment categories. And to compare them, we choose the odds ratio as a measure of effect, where an odds ratio of 1 means that there's no difference in the effect of the interventions. Comparing those patients treated with TNF inhibitors with those on corticosteroid therapy, the odds ratio turned out to be 0.42 in the favor of biologicals, meaning that these patients are less likely affected by this complication compared to those on corticosteroid therapy. And to decrease the imprecision of our data, we also determined the proportion of these events in the mentioned treatment categories, showing again that those treated with TNF inhibitors are less likely to be affected by this complication. And we chose the same methodology to compare patients treated with biologicals and immunomodulators, but here neither the odds nor the proportion showed any significant difference, basically within the two mentioned treatment categories. And similar results were found in patients compared based on their treatment of TNF inhibitors or aminosalicylates, meaning in the clinical practice that those patients who have active disease flare-ups, in those patients, the biological therapy is preferable over corticosteroids because it's going to be decreasing the odds of venous thromboembolic events versus regarding the maintaining treatment, it is basically, regardless of which treatment strategy we use, we are going to encounter the similar probability of these complications. So, through our work, we would have liked to assess the possible effect of certain medications on the venous thromboembolic events, and we would emphasize the fact that TNF inhibitors should be preferred over corticosteroids in those patients who have active disease flare-ups, because corticosteroids may have a certain prothrombogenic effect. Obviously, there are certain limitations to our work, as the included studies are retrospective observational ones. We are aware of the large heterogeneity of the IBD population. There are many confounding factors which should be taken into account when we have to assess the venous thromboembolic risk in the IBD population. And also, it is common knowledge that the concomitant medication interferes with the proper assessment of the individual drugs used in the treatment of IBD patients. So due to these limitations, there's very low certainty of evidence of our data. Still, we would like to raise awareness of this rare but severe complication of IBD and underline the importance of the so-called steroid-sparing therapy in those patients who have active disease flare and considered to be at high venous thromboembolic risk. And at the same time, to point to the future, as prospective large studies are needed to assess the proper causality of certain drugs in the venous thromboembolic risk. So we are glad to report that regarding our first project, it was accepted and it's published online in the Journal of Crohn's and Colitis. Our second project aims to assess the effect of newer drugs on the IBD-associated venous thromboembolic risk. So it is considered that this risk is increased in IBD patients basically due to the crosstalk and mutual influence of the inflammation and coagulation. It is considered that the systemic inflammation, it is the major risk factor of the coagulation in these patients. And the so-called vascular hypothesis means that besides the local gut inflammation, here we have to take into account the endothelial dysfunction, the increased coagulation, the increased activity of the coagulation factors, the hypofibrinolysis, and the abnormal platelet activation and aggregation. So all of these may have a role in determining the increased venous thromboembolic risk in patients with IBD. So based on these, we plan to assess the role of the newer drugs used in the treatment of IBD patients to measure their effect on the laboratory markers of this increased venous thromboembolic risk. So to answer our clinical question, we are going to use the PICO framework, and our hypothesis is that the newer drugs and the small molecules may also interfere with these lab data in a comparable measure as the TNF inhibitors. So we plan to conduct a prospective multicenter study where we are going to assess the hemostatic profile of IBD patients, and these results are going to be compared between the different groups, stratified among others, obviously by the anti-inflammatory medication, with the goal to measure the possible alterations of these lab data. We are going to classify our patients based on their demographic data, on their disease characteristics, and among others, on the current IBD therapy, and relevant lab data are going to be measured. We are going to exclude those patients in whom, based on their comorbidity, on their actual therapy, are going to be importantly interfering with these lab data. And our primary outcome is going to be measurement of the changes of the coagulation or fibrinolytic parameters, which are going to be measured in association with the used new biological drugs or small molecules. So in summary, we choose the most commonly used and the newer drugs to assess their effect on the increased venous thromboembolic risk in patients with IBD by our two projects, basically. So thanking you for your attention. I'm going to finish with the quote. The scientist is not a person who gives the right answers, he is one who asks the right questions. So waiting for your questions. Thank you.
Thank you for the presentation. So first of all, congratulations on the D1 publication. So my question now might be too late anyway, because it's published already. What was the reason for downgrading? Because you had a low grade of evidence for all the outcomes.
There were many, basically, based on the patient's characteristics. As we know, the inflammation and the activity of the disease is among the most important risk factors in the regard of venous thromboembolic events. And in this regard, not all of the publication used the more objective, let's say, activity indices which are used in the regular clinical practice to classify patients. Some of them use the medication as a proxy to determine the activity of the disease. That was one concern. And an important one, basically. So, and again, there are many other factors that should be also taken into account. So it is really difficult to just outline the role of certain medication, because demographic data, characteristics of the disease, the concomitant medication, so there are many confounding factors which are going to be interfering with the proper analysis of the role of the medication.
I can see that it still got published in a very high level journal, so clearly it's just a matter of the disease and not really a problem with the project. So congratulations again.
Thank you.
Congrats to publication, very interesting topic. I would like to also ask about this topic. Do you have any information about length of the therapy by glucocorticoids and if this has any role?
No.
And also if you have any idea about subgroups by either UC or Crohn?
So regarding the corticosteroid treatment, again, it's something that it was a confounding factor. Obviously, in the clinical practice, we know how to dose the corticosteroid treatment based on the patient's body mass, or body weight, and the length should be around 3 months, basically, from that dosage to termination of the treatment. These data were not published in any of the articles, although it's something that's regular practice. Regarding your other question, we did the subgroup analysis in each and every treatment category. There was no statistically significant difference between patients with UC and Crohn's disease, but data are available. It is in the supplementary material of our article.
And difference between corticosteroid that was used only in 3 months and those who were used like in patients who were corticodependent?
So we don't use steroids in patients who are corticodependent. There's a reason to initiate biological treatment in these patients. And there's another term used in certain articles, like chronic steroid treatment. I don't know what that properly means, but it is something that we came across too.